So I've been asked to start with a clinical case. It's just an excuse to introduce to the topic. And I find out a patient, a 60-year-old woman that runs a TV show in prime time. She has been virologically suppressed for several years on darunavir, ritonavir plus tenofovir FTC with excellent results. Her CD4 count is above 500. She has no baseline resistance and no history of treatment failure. Her HLA-B5701 is negative. She's diabetic and has hypertension. But in recent clinical visits, she revealed diminishing renal function. Creatinine is increasing, as you see. And she has been a heavy smoker for 28 years when she quit due to myocardial infarction. So trying to find out the different options, and I will not be asking you to vote because we don't have a voting system, but just to think about what other clinicians would do. Some probably would try to keep the current regimen and check renal parameters every other month. Somebody would like to go to abacavir 30C lutegravir, or to switch to taf-elbitregravir-COVID, or to darunavir ritonavir plus 30C, lopinavir ritonavir plus 30C, atazanavir ritonavir plus 30C, atazanavir unboosted plus 30C, or switch to the lutegravir plus 30C, or lately, I have no idea. So we will come back to this case at the end of my talk. So it's good, for, particularly for young people, as most of you are, what happened in 1996. In 1996, when HART was born, what we had was basically two studies. One was a study, I'm sorry, what's wrong here? This is the pointer.
Yeah.
Here?
Yeah,
okay,
forward,
sorry. Sorry about that.
But you have to point
Okay.
there.
So as you can see here, there were two seminal studies. One was with cidobudin 30C indinavir, presented by Trip Gulick, compared to two drugs, and the results were extremely better with three drugs at that time. And cidobudin DDI nevirapine was better than any of the two combinations without using three drugs. And the most popular regimen at that time was ACT-30C indinavir, and our patients had to take this number of pills that you can see there, fasting 1 hour before and 2 hours after, and also getting extra hydration because of renal stones. So it was really complicated. As a patient of mine told me, I'm living for the treatment instead of the treatment making me live. No? So it was really difficult at that time. So the question nowadays, in which we have new drugs, is it about the number of drugs, or is it about potency and safety? So why would you do that? Why would you go for reduced HART? First, you want to reduce toxicity, pill burden, and so improve patient adherence and quality of life. You have less chances of drug-drug interactions. Obviously, cost is an issue. If you lose one drug in your regimen, you are using less APIs. That means active pharmaceutical ingredients, which is the main driver of the cost of a drug. And you have a potential for long-term success because you are sparing classes just in case your strategy fails. Potential disadvantages. Obviously, you wouldn't select any type of regimen in which you sacrifice potency. This is a must. You have to show at least that you are non-inferior to the current triple drug regimen. Could it be that this double drug regimen is less forgiving for a patient that misses doses? Might we have reduced penetration in sanctuaries, and might patients require more frequent viral load monitoring? These are, I think, decent questions to address. We come from an era in which monotherapy was studied, and as you can see, monotherapy might work in different situations and with different type of responses. What you see in green is good. That means less than 50 copies. What you see in light blue is between 50 and 400. Gray means that the patient remains on study with more than 400,000 copies, and yellow is patients that were lost to follow-up or just stop the study. And as you can see, as initial therapy is not a good thing to do, because you only have about 60% success. If you do induction with 3 drugs and go for maintenance, it's a little bit better. But if you go for a true simplification study, that means patients that are undetectable without baseline resistance, and they were suppressed long enough, let's say 6 months to 1 year, and you simplify to PI monotherapy, this could work. And our colleagues in Europe, in some countries, particularly in Spain, as I know, and also in France, if I'm not wrong, they are using a lot PI monotherapy and with a good rate of success. So the question we posed was, if triple therapy works and monotherapy is a potential but not non-inferior simplification strategy, what about dual therapy? Could we try with dual therapy? Well, to move forward, you need a good couple. So some couples satisfies everybody, like this one. Some couples only satisfies the couple, like in this case. Some couples don't satisfy anybody. And some couples, they don't satisfy at all. No? So if we look at the first attempts, the combining PIs plus non-nucleosides, in general, we had good virological responses, but an increased rate of side effects. So we consider this strategy as a no-go because it is a failure. It might be as good as other strategies, but the tolerability is a big issue. Then some people tried with maraviroc, an excellent drug, and darunavir, the best PI we have. And guess what? Compared to triple therapy with tenofovir FTC and darunavir ritonavir, they were unable to demonstrate non-inferiority, and the DSMB stopped the trial. So it was a failure again. Then some people said, okay, if we use atazanavir and raltegravir, we know there is a drug-drug interaction that would increase the levels, so it should work. And you know what? If you look at the virological results in which non-completer is failure, it wasn't that bad. But if you look at the side effects, that they were higher in the arm that used atazanavir plus raltegravir, and the bad news is that there was a selection of resistance to raltegravir in the double drug arm. So it was also a failure. So looking at the kind of nucleoside sparing or nucleoside light regimens, we have several trials. This was one-arm trial. This was a comparative trial that I will talk about in a minute. There were some other trials, but either they were less effective than standard IRT, or were small studies with few patients with high viral load, like the PROGRESS study with lopinavir, ritonavir, and raltegravir, or other studies were poorly tolerated but effective. So if you look at here, the common factor here is 3TC. When 3TC is the second drug, it works with different PIs, as you can see here. Even in one of the studies, like the Atlas M, there was not only non-inferior, but eventually statistically superior. I'm not saying that 2 drugs is better than 3, but it's better tolerated, so this drove to superiority. So the NEED study, what could be wrong here? I mean, you're using the best PI, darunavir. You're using a completely new drug at that time, like raltegravir. Nobody had integrase resistance in the community. Nothing could be wrong. When you look at the results, in effect, you can see here, there was non-inferiority. Non-inferiority here. Okay, everything is okay. But if you go to the difficult to treat patients, more than 100,000 copies, or less than 200 CD4s, non-inferiority was not achieved. So this strategy is good for you as long as your patient has low viral load and decent level of CD4s. So back to the future. We come back to Lavigolin, one of the first drugs we had in our armamentarium. Why did we select 3TC as a potential companion for PIs and eventually for the lutegravir? It's once daily, it's well tolerated, it's cheap, it's generic, it has low, almost no side effects, almost no drug-drug interactions. And it's true that it's a drug with a low genetic barrier. But in case of failure, the mutation that you will select is the M184V. And as we know, M184V in general affects viral fitness. And there's a kind of residual effect, even in the presence of M184V. So I'm not advocating in favor of M184B. I'm saying that having this mutation is not the same as selecting the Q151M or so. So it's different. And on top of that, in presence of the M184B, tenofovir activity is enhanced. So we did the Cardel trial. You remember, lopinavir-ritonavir plus 3TC compared to lopinavir-ritonavir plus 2 drugs. What we saw was non-inferiority at 48 weeks that eventually in the patients that continued after 48 weeks was maintained at 96 weeks. But in the patients with 100,000 copies or more, this was also true, with being the difference even wider in favor of numerically larger for the 2-drug regimen, with 87.2% against 78% in the triple drug regimen. So this study was the first one to be a randomized clinical trial with enough statistical power to show that you can effectively treat naive patients with 2 drugs. So then the Spanish group did the OLE study, in which they used the same strategy, lopinavir-ritonavir plus 3TC, compared to continuing 3 drugs in patients that were virologically suppressed. And as you can see, protocol-defined virological failure, no difference. Any blip, no difference. Protocol-defined virological failure or any blip, composed endpoint, no difference. So the same strategy of lopinavir-ritonavir 3TC, in this case as a simplification strategy, did work. The Atlas M I talked about, again, is a simplification study in which you can see there is no non-inferiority, but here in the forest plot you can see that the confidence interval doesn't cross 0, so they can claim superiority in statistical terms. This is a meta-analysis done by Andrew Hill, and as you can see here, taking all the studies that include PI plus 3TC, there is a non-inferiority with a trend that favors PI plus 3TC. And obviously, I'm not saying that a PI plus 3TC is better than a PI plus 2 nukes. I'm saying that you will have less side effects, and this has been confirmed in other studies. So if you look at the more recent data presented by again, a Spanish group, is the dual trial, in which patients that were undetectable were switched to darunavir-ritonavir plus 3TC. And as you can see here, there's non-inferiority again with the same rates of non-virological response. And on Monday, I will be presented a late breaker abstract at this conference showing the same strategy, darunavir-ritonavir plus 3TC compared to the darunavir-ritonavir plus tenofovir 3TC. And it's embargoed until Monday by I'm smiling, so you can imagine that the results are not too bad. Okay. So the next question was, can we do that with the lutegravir? So we have shown, we have different studies showing that with PIs you can do that. So why dolutegravir? Well, it's low dose, as you know, 50 milligrams. It's easy to co-formulate. Safety profile is okay. A very low risk of DDIs with a very decent genetic barrier in vitro. Multiple mutations are required for high-level resistance. And in treatment-naive randomized clinical trials, no patient treated with dolutegravir 50 milligram plus 2 nukes has developed integrase resistance or nucleoside resistance. To be completely honest, in real life, there have been a few cases in which the resistance was reported. The first one was at CROI this year, a patient with more than 2 million copies and less than 20 CD4s, selected resistance for integrases. So we need to be careful, and even with drugs with high genetic barrier, resistance in some cases might emerge. So what we did was a very carefully designed study, the Cardel study that was presented last year, and in which we are presenting at this conference the 96 weeks results, which are very good. And we enrolled 2 cohorts of 10 patients each. The second cohort was enrolled once we were reassured that nothing wrong was going with our patients. Patients were treatment naive and had less than 100,000 copies and were Hep B negative. And as you can see here, eventually 4 patients that at screening had less than 100,000 copies, 4 of them had more than 100,000 copies at baseline. So it was unexpected for us, but it was also a reassuring message. As you can see here, in green is patients that achieved less than 400 copies, and in yellow, less than 50. And so that early as 4 days, we had viral load measurements at day 4, day 7, week 2, 3, 4, etc., because we wanted to see the kinetics, if the kinetics were the same as in triple drug therapy. And as you can see, by week 8, everybody was less than 50, and by week 4, everybody was below 400 copies. So I think that the results are very superimposable with those that you see in triple therapy. CD4 increase was almost the same that you can see in any other study. We had one patient with a severe adverse event, and we had one patient that had protocol-defined virological failure, was a low-level virological failure, and the patient eventually, he was taken out from the study because this was protocol-defined, but the patient resuppressed with the same regimen of 2 drugs without any change, but out of the study. Then we have a simplification study, the Lamidol study, in which patients that were undetectable were switched to the lutegravir 3TC, 110 subjects, and as you can see, the results were extremely good. So eventually, only one patient showed virological failure without resistance. So we published with Sharon and other people kind of state-of-the-art on dual therapy that was in 2016. And as you can see, as you can read here, our conclusion at that time was that it's not currently possible to recommend widespread adoption of novel dual therapy regimen, but eventually, if the studies that were ongoing at that time could lead to a shift in the treatment paradigm of HIV. So it was a glimmer of hope, but also a note of caution not to move very abruptly into 2-drug regimen. But then we saw the results of the SWORD studies. SWORD studies have been mentioned by Sharon this afternoon. Patients that were undetectable on any regimen were randomized to 1-to-1, either to continue antiretroviral therapy or to move to dolutegravir rilpivirine, and then everybody at week 52 was moved to dolutegravir rilpivirine. And you don't need to be a statistician to understand this, that the virological success was exactly the same. And as you can see here, the non-inferiority was absolutely shown. Virologic non-response and no virological data were almost the same, with the advantages that switching had a neutral effect on lipids and significantly improved bone turnover markers. Whatever this means, we really don't know what is the clinical significance of this, but anyway, be it bone-specific alkaline phosphatase, be it osteocalcin or procollagen 1, as you can see, was better in the 2-drug arm. Then we have the Latte 2, again talking about cabotegravir. In this time, we are talking about naive patients, and these patients has oral leading dose of cabotegravir plus abacavir 3TC, and then were randomized to continue this regimen or to go for Q8 weeks or Q4 weeks with cabotegravir in different doses plus rilpivirine in different doses again. And the results, as you can see here, the results in both arms were comparable to oral cabotegravir, but more virological failures were seen every 8 weeks. So for treatment, at least, the recommendation will be every 4 weeks instead of every 8 weeks. And it's noteworthy to say that one patient in the every other month's group developed resistance to non-nucleosides with the K103N, and also the K184R, which is, as you know, one of the signature mutations, together with the 155, that you need to take in account that this is the way to resistance for the overall class in integrase inhibitors. Again, the same as the former speaker showed, there was the kind of injection site reactions, but the overall satisfaction of the patient was surprisingly high. So even if it gives you a little bit of pain, please don't compare it with T20. T20 was really terrible. They gave you nodules and severe pain. This is the site injection reaction. And be reminded that in clinical trials, you are proactively asking the patient, does it hurt? Did you have any problem? Which is not the case probably in clinical practice. So even so, asking proactively, as you can see, the majority of the patients were satisfied with this regimen. So this is good news. Rochelle Walensky published a paper last year in CID in which she made, with her group, she made a calculation about the economical impact of dual therapy with dolutegravir 3TC. And the conclusion was that they could save 100 million a year if the efficacy of the trials were at least 90%. So far, the PADL study showed 90% and observed failure with only 5%, so even eventually 95%. We have the ACTG 5353. The results will be presented at this conference, and the final answer will be given by the Gemini studies, in which 3TC plus dolutegravir is being compared in 1,400 patients to dolutegravir plus tenofovir and 3TC. And we will see the final results probably in Amsterdam next year, and this will give us the final response. More recently, we published an updated analysis of dual therapy, and now we can say that the preliminary results of the studies that we are reviewing are really encouraging, and it might be that the combination of dolutegravir plus rilpivirine or dolutegravir plus 3TC could provide a once-daily regimen with very limited toxicity, and could be an alternative in the future, provided that the Gemini study shows that no resistance emerge. This is the main issue. I think that it's not negotiable, the issue of potency and selection of resistance. So far, we need to be careful in terms of prescribing this. As state of the art, I would say that switching to dolutegravir plus 3TC or dolutegravir rilpivirine will become very shortly in many of the guidelines as standard of care. For naive patients, I think we need to wait until the Gemini study give us the final answer. So, coming to the end, what do we need? We need well-designed non-inferiority trial versus triple combination with enough number of patients tested in the new strategy. Be reminded that in the Gemini we will have about 700 patients taking dolutegravir and 3TC, so we will have information there. We need to assess the risk for both for the individuals and also for public health concerns. Would this double strategy seed resistance in the community? This would be a no-go. And we need to identify what are the patients that are more likely to succeed or to benefit with the new strategy. And we need also to see durability, because the first results will be 48 weeks, which would be hopefully very good, but we need to see if this is sustainable about 96 weeks, 144 weeks, and so on. So the future directions is we can see clearly in our treatment arena two directions. One is using triple drug therapies or eventually combining 3 or 4 drugs, and on the other side, combining 2 drugs. So I don't know if we will see both strategy aligned and living together in the guidelines, or if eventually 2 drugs can supersede the other strategy. So if the results of the trials that I mentioned will be positive, a new paradigm for first-line treatment and early switch may be generated. And in the area of test and treat, in which we need to put on treatment 37 million patients. As of today, UNAIDS tell us that 19.5 million are on treatment. That means that we need to do almost the same. We need to duplicate the number of patients that we have on treatment now. This could be a safe and effective option for switch and maybe for first-line heart. And this could be an important contribution to the final strategy we are aiming, that is controlling the epidemic with the 1990 strategy. Thank you very much.